I'll pass on the microphone to Michelle Wong. Michelle Wong is a nephrologist and research scientist who works closely with Arbor Research. Michelle is based in Vancouver, British Columbia. Michelle has also led a manuscript just accepted for publication dealing with trends in inter-dialytic weight gain over time, which she'll present some highlights from in just a moment. Michelle.
Thanks very much, Bruce. So first of all, I'm going to describe the DPM trends in inter-dialytic weight gain in the U.S., and then I'll go through some of the data from our manuscript on international trends. So we see here that this is intra-dialytic weight loss that is shown here, and this is within a dialysis session, the weight change. And so we often use this to estimate intra-dialytic weight gain, and these two variables are highly correlated. And this is a relative measure here, as it's presented as a percent of post-hemodialysis weight. And we see the median in the blue line has decreased from about 3.1% of post-HD weight in 2010 down to about 2.5% of post-HD weight in April 2016. And we see that the 90th percentile has also seen a similar decrease in the intradialytic weight gain. And this trend has been consistent when we look at various subgroups, including race, dialysis unit type, and geographic area. And those graphs are also available on the DPM website if you wish to look at those various subgroups. Okay, next slide. And so this is the title of our manuscript looking at inter-dialytic weight gain trends internationally. And it's currently in press at AJKD. Next slide. So in this study, we assessed trends in inter-dialytic weight gain by region, including Australia, New Zealand, Canada, Europe, Japan, and the US, using cross-sectional samples of patients within DOPPS Phase 2 to DOPPS Phase 5, and this covers the span of over a decade, from 2002 up to 2014. And we also looked at associations between inter-dialytic weight gain and patient and facility factors, as well as associations between inter-dialytic weight gain with clinical outcomes, including cause-specific hospitalizations and mortality. And we had data from over 21,000 participants with end-stage renal disease on chronic hemodialysis with a hemodialysis vintage of greater than or equal to 1 year. Next slide. So similar to the trends that we see in the U.S. In the DPM slide previously shown, we do see a trend of decline in mean inter-dialytic weight gain across all regions. And the decline was by 0.8% of post-HD weight in Canada, and a decline of 0.5% of post-HD weight in the US and Europe. The decline was a smaller magnitude in Australia, New Zealand, and Japan. But there was still a consistent trend of decline in each region. Next slide. And categorically, we do see that there's also been a decrease in the percentage of patients with high inter-dialytic weight gain above 5.7% of post-HD weight, and that's shown in the dark bars at the very top of each of the bar graphs there. And this cutoff has been shown to be associated with increased risk of mortality in patients who have a post-HD weight of greater than 5.7%.
And Michelle, just to clarify for folks as well, that 5.7%, if you assume a typical 70-kilogram person, that will be 4 kilograms as well. So 4 kilos of weight.
Right. Okay, next slide. And so we also looked at associated trends, and we also observed a decrease in mean pre-dialysis systolic blood pressure, with a decline of about almost 6 millimeters mercury in Canada over the span of those 10 years, and Japan had a decline of 2.2 millimeters of mercury on the lower end of that range of blood pressure changes. And we did not see a real significant trend in post-dialysis systolic blood pressure, but because we did observe a consistent decline in pre-HD blood pressure, this most likely reflects the extracellular volume status of patients. And so the trend of decrease in pre-HD blood pressure may be attributed to the decline in inter-dialytic weight gain. And next slide. And in order to look at other factors associated with this decline in inter-dialytic weight gain, we also looked at the trends in mean dialysate sodium, and we did see a significant decline in all regions as well, most notably in the U.S., where facility mean dialysate sodium decreased by 1.7 milliequivalents per liter. In Canada, declined by 1.1 milliequivalents per liter, and less than 1 milliequivalent per liter in the other regions.
And Michelle, this and for the audience, this sort of reflects a tension, as it were, in the U.S. versus elsewhere, where in some other regions, particularly in Japan, there's the sense that keeping dialysate sodium relatively high may help maintain hemodynamic stability on dialysis. And so they've had the tendency, as you see, to have substantially higher dialysate sodiums than the U.S. And the U.S. here, you see, we also do within the, although it's not reflected here, we see differences in practice amongst dialysis centers and between dialysis providers here in the U.S. as well.
Right, thank you, Bruce. Okay, and so next slide here. So among the modifiable factors associated with inter-dialytic weight gain, the most notable was the facility mean dialysate sodium. And we found that in the linear regression analysis, every 1 milliequivalent per liter of dialysate sodium was associated with higher inter-dialytic weight gain by 0.13% of post-HD weight. And so overall, dialysate sodium accounted for approximately 29% of the decline in inter-dialytic weight gain. We did look at other patient and facility factors, and we did not find a significant association between the presence of a dietitian or the likelihood of a dietitian counseling for high inter-dialytic weight gain in that analysis. And it may just be that the variation in the quality of the dietitian-patient interactions or the effectiveness of their strategies to improve adherence to salt intake were not captured by our data. Okay, and we also looked at the association between inter-dialytic weight gain categories and clinical outcomes, including mortality and hospitalization. And compared to the reference group of 2.5% to 3.99% of post-HD weight, there was an elevated risk of mortality with IDWG greater than 5.7%, and that had an adjusted hazard ratio of 1.23, which was statistically significant. And we also found that that there was a higher risk of fluid overload hospitalization with IDWGs greater than 4%, and that had a hazard ratio of 1.28 for the 4% to 5.69% category. And this was a graded response, so the hazard ratio was higher at 1.64 for the IDWG above 5.7%. Okay, and next slide. So in the U.S., we did find a large decline in IDWG from 3.1% to 2.5% over an approximately over a greater than 5-year period. And across DOPPS regions, both IDWG and the proportion of patients with IDWG greater than 5.7%, categorized as very high IDWG, the proportion also declined over a period of over a decade. And the reductions in relative IDWG were partially explained by reductions in DNA. As I mentioned, approximately 29% of the decline in IDWG was explained by DNA. But there are other factors as well that are likely contributing to this decline in IDWG. So one of the limitations of our study is that we did not assess dietary salt intake. So that is likely a large contributor to IDWG. We did not find any significant changes in nutritional variables, such as NPCR, over the same period of time. So that likely did not account for the change in IDWG. And certainly there, with the recent initiatives, such as the Volume First Quality Improvement Initiative that was proposed by the large dialysis organizations in the U.S., this has likely, or this may have impacted the IDWG in terms of highlighting the importance of volume control in HD units. And as well, target weight assessment techniques such as bioimpedance and crit line and their use over the last decade may have also led to improvements in or declines in IDWG. And focusing quality improvement initiatives towards reducing these high occurrences of IDWG may further improve outcomes in HD patients. And so now I think we're just going to look at the responses to your polling questions and see if we can discuss a little bit more about your answers.
Okay. Right. Brian, just to be clear, does the audience see the list of questions still?
Yes, they can see that if they click on the polling tab in the WebEx feature. Okay.
Yeah, I could go through the results of the questions that we have. Michelle, thank you very much for the presentation, also for leading this manuscript, which I think is a very important manuscript. Again, the U.S. DOPPS Practice Monitor, which is on the public website, does show quite substantial decline in weight gain, inter-dialytic weight gain here in the U.S. over the last 6 years. And indeed, as Michelle reviewed, if we go back over the last 12 plus years, both in the U.S. but also internationally, we've seen substantial improvements in weight gain, which I think is great. And hopefully will be a real benefit to patients, as Michelle notes, with an emphasis on hospitalizations and rehospitalizations here, perhaps that trend will really help with respect to those numbers. So our poll questions, just in your thoughts about, and your sort of gestalt or feeling about how things are going into your dialysis units. First question, the average inter-dialytic weight gain in patients in my unit now compared to 5 years ago among people who responded, we had roughly 50 to 60% saying that weight gain is now lower than it used to be, and the rest, about 40%, saying that weight is unchanged or perhaps even higher. Secondly, the emphasis provided to patients to limit salt and fluid intake is greater. Actually, that's pretty overwhelming. Actually, about 80% of respondents said that they're now placing more emphasis on behavior modification, attention to diet, in particular salt intake. Good. And then thirdly, the frequency of assessing target weight by unit compared to 5 years ago. The majority of respondents, around 75%, said yes, the target weight is assessed more frequently, and that assessment is occurring clinically, really based on exam, but also assessment of standard dialysis variables, blood pressure, et cetera, and trends in weight gain, et cetera. Interestingly, in other countries, the use of bioimpedance, critline, et cetera, for assessment of target weight is actually quite prominent, certainly in some of the countries that we study. But here in the States, still not the predominant approach. Actually, roughly 20% of respondents said that the use of those technologies has increased recently. Only about 5% of respondents said that frequency of assessing target weight has not increased. And then lastly, if IDWG is lower at your unit compared to 5 years ago, how does that affect your patients? And this is, of course, a very qualitative sort of question that we asked you. But a high majority, again, around 75% of respondents said that they feel that patients feel better as a result of this. The rest, around 25%, said no clear difference that they appreciated. Okay, good. Thank you again, Michelle, and thanks for those who responded to our poll questions. We'll move on. We did have one question going back, or a question from the audience that I wanted to respond to related to inter-dialytic weight gain. And the question was as follows. One of the slides we have seen is that the average inter-dialytic weight gain is highest in Japan, higher in Japan than both Europe and the U.S., and yet mortality in Japan is lower than in Europe and in the U.S. So why is that? If indeed we talk about the importance of limiting inter-dialytic weight gain, why is it that the Japanese on average have higher weight gain and yet survive longer? I think that it's a very good question. We find this actually comparing Japan to elsewhere, sort of paradoxically, we see some surprising differences in practice. There may be two potential answers for this particular observation. One is a confounded one, meaning patients in Japan survive longer despite having, on average, higher inter-dialytic weight gain. And another example of this that this calls to mind is KT over V. We actually found some years ago that a higher proportion of patients in Japan had KT over V less than 1.2, and yet than elsewhere in the world. And it turns out that if we look at KT over V, even within Japan, we see clearly that KT over V less than 1.2 is associated with worse outcomes and therefore should be avoided. Actually, in recent years, in large part in response to these data, that in Japan there are far fewer patients with KT over V less than 1.2. So I might suggest that if we looked at patients in Japan with very high inter-dialytic weight gain, such as 5.7% or higher, they are likely to have elevated mortality, and that extreme weight gain should probably be avoided. The other point with respect to Japan is that, with any of these variables, there's probably sort of a sort of happy medium or optimal range of inter-dialytic weight gain. Of course, if we cut too low, you start to compromise nutrition. which is, of course, very important as well. I mean, at some point, there's going to be an uptick in mortality at too low an inter-dialytic weight gain. So they may, in part, be avoiding the excessively low percent inter-dialytic weight gain also. Lastly, I would note, the DOPPS group did publish in The Lancet a couple months ago on trying to understand a bit more about interregional variation differences in survival. And there we actually have a table, quite a long table, describing practices that are quite different in Japan compared to elsewhere. Blood pressure is another one, where blood pressure levels among dialysis patients are higher in Japan than elsewhere. Okay, well, thank you for that question.